At the outset, I would sincerely apologize for the delay due to technical snag happened here. Next 40 minutes, I am going to discuss about the biggest challenges in the ICU infections due to the global antibiotic resistance, and I am trying to simplify at the end of the day what should be the way forward. I am going to do next 40 minutes. I'll try to simplify as much as possible to you there. This is my disclosures. I'm a poor ID doc. I don't make big money. I'm the least earning specialty among the specialists there. Why? We are trying to solve the problems created by others. For example, orthopedic surgeons. They put a lot of implants, make big money. I'm trying to solve the infections created by surgeon. I'm earning least compared to the surgeon what you're putting the device there. I'll straight away begin with the case now. 62-year-old male presented with an abdominal pain of 4 days duration. He underwent ERCP for a calculus cholecystitis. The pain was due to basically gallstone. Post-procedure, before procedure the patient was stable. The only concern was pain. Post-procedure, the patient developed fever, chills, and transiently went into hypotension, requiring a lot of fluids. The past medical history, he was hospitalized 15 days back and received 2 units of blood transfusions for suspected anemia. The anemia was evaluated, thought of nutritional anemia. Because of abdominal pain, he was not taking proper food, but somebody given amoxiclav at the time of discharge. I really do not know what is the reason for amoxiclav for a patient hospitalized for anemia. On examination now, the patient is febrile, tachycardic, tachypnea, and BP was on the lower side in spite of receiving some fluid boluses there. On basic investigations, the WBC count was bit high, polymorph predominant neutrophils were there. X-ray showed some vague infiltrates. So, I'll open up the poll now. How many want to start meropenem for this man? Already received amoxiclav recently. Whether you want to start with meropenem or whether you want to start piptazo or whether you want to start colistin plus tigecycline. I don't want to take chance. I want to hit hard. Start coli plus TG or start cevaprosone sulbactam or start cefepime whether we can't start cefepime. So this is a challenge we got it now, cefepime plus tazobactam. Okay, keep holding. We'll end at the end of the day. We'll discuss this case there. My second case for today is 56-year-old female, systemic hypertension, not a diabetic, only hypertensive lady, presented to me with a history of fever and chills. In February 2019, she was admitted in another outside hospital for community-acquired pneumonia, diagnosed to be H1N1. Received multiple antibiotics. Because the stay was a turbulent one, she stayed quite long in the ICU. On March 2019, almost 15 to 20 days of stay, she got discharged. Went home and started developing ESBL E. coli in the blood. Urine routine showed a lot of plus cells, treated with cevaprosone sulbactam. Now BP is stable, but slightly on the lower side. Oxygen, minimal oxygen, 3 to 4 liters of oxygen required. Still complaining of urgency. Total count was 14,000. Urine routine showed plenty of pus cells. Started piptazo. Blood grew this time E. coli. So multiple antibiotics in February. March, one course of E. coli, ESBL E. coli bacteremia. Received cevaprosone sulbactam. Improved. Again getting GNB, probably E. coli. Started with the piptazo, not moving forward, and slightly hypotensive. Oxygen requirement slightly up, but still WBC counts are very high. What do you think? You want to change it to meropenem or you want to continue piptazo? Wait for the best response. Continue piptazo along with colistin. Change it to meropenem plus colistin. Wait till what is the E. coli sensitivity. Get back the sensitivity on responding to it. Whether the patient can wait. Whether the hemodynamics can allow to wait. So my objective today is antibiotic resistance. What is the antibiotic resistance trend globally as well as an Indian scenario? I'll try to focus a little bit of Chennai scenario also there. Challenges due to antibiotic resistant infections. What are all the challenges you face in dealing with antibiotic resistant infections? Way forward, that's most important for today. I'll try to summarize at the end. I can only explain to you, understanding your responsibility. Don't put the blame on or don't put heavy weight on me to understand for your sake. Just I'll explain to you. Understand is your responsibility. Global antibiotic resistance pathogens. If you see WHO and CDC, they told clearly these are all the bacteria of real concern. If you see the WHO list, 3 bugs tops the list. All are carbapenem resistant organisms. Carbapenem resistant Enterobacteriaceae, even third generation resistant Enterobacteriaceae. That means ESBL producing organisms. Carbapenem resistant Pseudomonas, carbapenem resistant Acinetobacter baumannii. As far as CDC is concerned, they divide the threat into 2 threats. One is an urgent and second thing is a serious threat. Urgent threat, carbapenem resistant Enterobacteriaceae. As far as a serious threat is concerned, MDR Acinetobacter, third generation cephalosporin resistant Enterobacteriaceae, MDR Pseudomonas. So these are all the major things CDC is worried about. Since it is in US situations, they are worried about lot other things also, like Neisseria gonorrhoeae, Salmonella typhi, MRSA, VRE, because US has got a major problem with MRSA and VRE. Indian hospitals also start saying lot of MSSA, I can put it, not MRSA, lot of MSSA as well as VRE is likely emerging in Indian scenario. If you see what are the top 4 or 5 bugs for the worldwide, these are all the 4 or 5 bugs I can put. One is called Acinetobacter baumannii. Second thing is called Pseudomonas aerogenisa. Third thing is Escherichia coli. Klebsiella species resistant to third generation cephalosporins and Klebsiella resistant to carbapenemase producing organisms. Why they consider as a threat? They are considered as a threat because it's very difficult to treat. The first green bar shows they are very difficult to treat. Second thing, the mortality is very high. If you fail to give an appropriate treatment, the patients will not go back home. Third thing, this causes significant healthcare burden, healthcare associated infections. Trends of resistance, the resistance trend is always going up. Prevalence of resistance, even in the community the resistance is going up. Transmission from one person to other persons, one hospital to other hospitals, the transmission is possible here. Community burden is also going up. Prevention in the community settings. Prevention is in the community setting. If you see the map, the old antibiotic resistance is going to affect the country's GDP. This is the impact of antibiotic resistance. That's why CDC and WHO says this is a serious threat, urgent threat, emerging threat. We need to address this threat. Unless we need to address the threat, it's very difficult for us to do the thing there. So this is the most important thing for me. We need to address the thing. What is an Indian scenario? This is a 2009 scenario. 2009 scenario, the 3 common bugs, Acinetobacter baumannii, E. coli and Pseudomonas. See, in 2009, Klebsiella is not even emerged in the thing. Only Acinetobacter. If you see the carbapenem resistance, Acinetobacter was resistant to carbapenem 90 to 92% in 2009 I am talking about. This paper produced by me in 2011 to 2012. But Acinetobacter baumannii was resistant in 2009 itself. But Klebsiella rim was missing. These are all the 3 top bugs followed by gram-positive organisms in 2009. But what happened to the Indian scenario in 2010? The year 2010 is a significant year for Indian scenario. Why? First made in India product came into India. The first made in product, that's called NDM1, New Delhi metallo-beta-lactamase. Kumarasamy et al. Produces this major paper saying that carbapenem resistant E. coli, carbapenem resistant Klebsiella pneumoniae has emerged in India. Before that, Acinetobacter baumannii was resistant to carbapenems, but in 2010, the major year that divided first E. coli and Klebsiella, ordinary community bacteria, usually respond to any antibiotic like cephalosporin, ceftriaxone, fluoroquinolones, become resistant to a powerful antibiotic carbapenem. That's why the NDM1 challenge emerged in 2010. The next one, the distribution happened. Previously it was localized, but it's now distributed across continents. Across continents, the NDM1 and its close friend OXA48 is distributing. Both NDM1 and OXA48 carbapenems will not work. That is a major underlying theory. And India is in the red. India is in a red map because all over India this bug is distributed. Apart from India, other countries also facing the problem like China. But the problem, the distribution type. India has got a problem of NDM1 and OXA48. But the problem of US is KPC. There is a huge difference between KPC and NDM1 and OXA48. I'll come back during my treatment sessions. What is the difference between NDM1 and OXA48 there? So this is the Indian top bugs. What are all the bugs Indian government is worried? These are all the 4 bugs Indian government at present is worried. One is E. coli, but fortunately E. coli is not bad. Only E. coli resistant to 3rd generation cephalosporin is a concern. The resistant to carbapenem is not great, still 5 to 7% depending upon the hospitals. Northern part of India, the resistance going up to 25 to 30. Some other centers it touches about 40. But what is a real concern? Klebsiella pneumoniae. Klebsiella pneumoniae resistant to carbapenem is going up. It is catching up similar to your Acinetobacter baumannii. Acinetobacter baumannii, it remains static at 70 to 90% resistance. What is good thing in the recent years? Pseudomonas aerogenica resistance is going down. Carbapenem is not working, but fortunately cefepime, ceftazidime, cephalosporin sulbactam, piperacillin tazobactam, cefepime tazobactam, these are all working for Pseudomonas. So the only good news in Indian scenario, Pseudomonas is getting less resistant, Acinetobacter as well as Klebsiella. The real worry is Klebsiella pneumoniae getting resistant to most of the antibiotics. That is a real concern for Indian scenario. If you want to touch upon Indian scenario, I am touching upon Chennai scenario. This is a paper we produced. Couple of years back, showing that what happened in 2003 and what happened in 2013. The year of divide is 2010, remember. 2003, somebody calling from me emergency, or some call I received from ICU. Patient is sick, shocky, septic. What antibiotic I need to start? What I used to say, start 1 dose of meropenem, give 1 dose of vancomycin. Meropenem 1 gram, vancomycin 1 gram. This is a standard mantra I used to tell. What happened? My daughter used to pick up the phone. Any call from ICU, she used to say Mero 1 gram, Vanco 1 gram, keep the phone down. This is what working in 2003. But unfortunately, in 2010, Indian made product came into India. NDM1 entered India. What happened? My carbapenem resistance is going up 50%. Even if I say carbapenem, the resistance rate is very high. The chances of success is going to be almost 50-50, tossing a coin. Head comes, the person may succeed. Tail comes, the person may fail. This is a scenario. If you see the culture plate, in 2009, almost all the antibiotics is working. In 2019, hardly 1, maybe 2. If you are lucky, you can get 2 antibiotics. If you are not lucky, nothing will work. This is a scenario in 2019 they put, but for me in Indian scenario, 2013-14 onwards, the scenario is continuing and the graph is keep going up. It's not going down. That's more important thing there. What are all the challenges you face? What is the difficulties? I told what is the problem of resistance in Indian scenario. What is the problem in worldwide? What CDC considers, what WHO consider, what Indian government considered, what is shown in Indian map and what is shown in Chennai map I shown to you. But now I am showing what is the problem of resistance. The first problem for physicians and treating clinicians is they need to aware of it. When New Delhi metallo-beta-lactamase came in India in 2010, I did my paper in 2012. The awareness about NDM1 in 2012 is hardly anything. Hardly anything for NDM1 in 2012. Hardly 30% of Indian physicians aware NDM1. What do you mean by NDM1? It is ordinary E. coli, ordinary Klebsiella pneumoniae, resistant to most powerful antibiotic, imipenem and meropenem. But unfortunately, most of the clinicians in 2012, they do not know what antibiotic to treat. So the awareness is lacking. When antibiotic resistance is growing up, we need to do update. I thank the Fusion Pharmaceuticals because they are updating your knowledge, giving you forum. What resistance is emerging? What is NDM1? What is OXA48? Yes, this is a good forum. You can learn these things, resistance mechanisms, and what antibiotic is emerging also, they are giving it there. Second challenge. Once the antibiotic resistance is growing up and new antibiotics is not coming into market, what we are going to do? Whatever antibiotic we got previously, the spectrum starts shrinking. The spectrum starts shrinking day by day. Previously, when I was doing my undergraduation, post-graduations, any patient septic, shocky, we used to give ceftriaxone. That's what most of the Indian critical care guidelines told in 2010 and 2011. Give ceftriaxone and doxy, most of the things will be taken care. But if you see, hardly the 3rd generation cephalosporins, very few role. Most of the thing it is in ESBL. 3rd generation cephalosporins will not work. So what we start using? BLBLI in the form of cephalosporin sulbactam. in the form of piptazo, and one new addition they call cefepime tazobactam came into market recently. Even though this molecule is not approved worldwide, in Indian scenario this is a very good molecule. Why? Cefepime will take care of your MC producing enzymes, and tazobactam will take care of your ESBL producing enzymes. So if the person has got ESBL or MC producer, cefepime tazobactam will take care most of the thing. But where it misses out carbapinamase producing organisms. Then came tigecycline. Tigecycline is a wonderful drug, cover almost all the bacteria. If you see the spectrum, except Pseudomonas, some Proteus, these species Providentia, Proteus, 3P we call it, Proteus, Providentia, Pseudomonas, tigecycline will not got no actions, inherently resistant there. Then comes carbapenems. Carbapenem has got most of the cover, but the problem from 2010 onwards in Indian scenario, carbapenem resistance start emerging there. Then what happened? We given a rebirth to colistin, polymyxin Bs. Polymyxin B and colistin start emerging from 2008 and 2009. What is the end result? Carbapenem resistance has emerged, but nowadays we are start seeing colistin resistant bacteria there. So this is a rebirth of colistin. From 2009 onwards, the graph of colistin keep growing. I think from 2019 onwards or 2018 to 2019 onwards, the graph may go down. Why? I'll come back in a minute later. Lot of new things is going to come in Indian market, and a lot of irrational, otherwise you can call irrational combinations is going to hit the market. We need to revise our strategy. By changing from colistin to other things there. So the graph is going from 2009, almost 10 years. Single dominant leader in antibiotic usage was colistin and polymyxin B. But what happened if you start using the rebirth, or if you start using a new molecule like tigecycline? Once you start abusing the antibiotic, once you start overusing the antibiotic, the resistance is going to emerge. That's what happened to tigecycline. Came into market in 2009 and 2010. Hardly within 2 to 3 years, the resistance of tigecycline went up to 20 to 30%. The resistance of tigecycline went to 20 to 30% within 2 to 3 years. Why it happened? Underdosing. The dosing of tigecycline previously was not clear. The company itself is under promoted this molecule. Why? We need to give 200 mg stat followed by 100 mg BD. Except few indications, for example, intra-abdominal sepsis, skin and soft tissue, we can give 50 mg BD dose. But for a pneumonia, for a bacteremia, for urinary tract infections, even though it has got not approved for urinary tract infections, Indian scenario sometimes needs tigecycline. If you use double the dose, instead of reaching 15% in the urine, you may try to reach 30% in the urine. That is why we start using tigecycline. But what is the impact of underdosing? Underdose results in lot of resistance to tigecycline. That's why use maximum dose, do not underdose it there. So if you start using antibiotic, whether old one, whether new one, you are going to get lot of resistance there, keep in mind. So what is the impact? The resistance has created one, resistant bugs. The resistance has created inappropriate therapy in ICU. We do not know what we are going to get it. Suppose if the person gets sick, shocky, you are starting meropenem. 2 days later, the culture report came back and told this is carbapenem resistant bacteremia. What will happen? So it causes inappropriate therapy for the patients. That's a major impact we are getting it there. So the other impact is inappropriate therapy. That's a major reason. We need to be careful in selecting our antibiotic. If your choice of antibiotic is wrong, the patient will not go back home. What is the final impact of a resistant bacteria? This is the final impact of resistant bacteria. If you see in Indian scenario, colistin resistant bacteria start emerging. Once colistin resistant bacteria start emerging, what will happen? Best of hospitals, best of ID consultants, best of infectious disease consultant available everywhere. But see the last column. This is a busy slide, but see the last column. The last column clearly showed the person not going back home. It creates increased mortality there. Almost 24 hot patients has got carbapenem and colistin resistant bacteria. Almost 16 has got bloodstream related infections. Others may be ET secretions, urinary secretions there. But bloodstream related 16 bacteria, colistin resistant bacteria. If you start treating with different combinations, the ultimate aim of going home is hardly 13 patients died, 2 patients lost to follow-up. Essentially, DAMA, the person died maybe in the other center or in the home. Only 1 heart patient survived. So this is the statistics of colistin resistant bacteria. Similar trend is for carbapenem resistant. Almost 50 to 70% of the people will die. So the impact of resistance is huge. Either it kills the patients or prolong the course, increases the cost of antibiotic, increases more resistance. This is why we need to address today. This is why I am trying to address in next couple of slides there. So what should be the way forward? It's easy to copy American guidelines, easy to copy IDSA guidelines, easy to copy European guidelines. But for Indian scenario, Indian growths are different. Indian bugs are different. Indian resistance mechanism is different. As I told earlier, previously NDM1, but now what is emerging in Indian scenario? OXA48 is emerging there. But what is the problem? Even though carbapenem resistant bacteria emerge in other parts of the world, but what is emerged in other parts of the world? KPC. KPC has got a lot of therapeutic options, a lot of treatment options. But for your NDM1 and OXA48, very few options are available. This is an Indian scenario. So how to approach? What should be the way in your hospital? If you got a sick patient, first approach is whether the person has got infections or not. That's most important thing we need to remember. Whether the person has got infected or not, whether the person is septic or not. The second thing is what sort of host you are going to deal with it. Third, where is an infections, what is the pathogen we are going to address, and finally what antibiotic I want to use. This is most challenging for every clinicians there. This is most challenging for every clinicians. So this is a surviving sepsis guidelines. If you see the surviving sepsis guidelines, how it defines a sepsis: life-threatening organ dysfunctions due to dysregulated host response. What do you mean by dysregulated host response? I am not sure. What is dysregulated host response? I am absolutely clueless. How to define dysregulated? I am clueless. And this definition is tried in US hospitals, referral hospitals, where they treated a lot of community-acquired pneumonias, they treated a lot of skin and soft tissue infections. Based upon the data, they are given these guidelines. And third, what is the etiological agent? Sepsis guidelines does not define what etiological agent causes the problem. Nobody knows it there. That's the problem with septic guidelines there. So what is the new way of defining sepsis? Don't consider sepsis as a bad name. I can put sepsis as an heterogeneous disorder. It is a heterogeneous disorder. It contains many different diseases and many different infections there. It has got a different characteristic features. Clearly more than an infection. That's more important thing there. Don't consider sepsis as a bad thing. Sepsis is more than infections. It affects the organs. It affects the organs, particularly pneumonia, urinary tract infections, bloodstream infections, meningitis is possible. And we need to know the organisms also. So this is a new concept in sepsis. Instead of telling sepsis, we need to know where is the sepsis. Whether it's a urosepsis, whether it's a hospital-acquired pneumonia, whether it's a meningitis, whether it's a skin and soft tissue, whether it's abdominal sepsis. If it is abdominal sepsis, whether it's a primary peritonitis, secondary peritonitis, tertiary peritonitis, we need to know. And instead of telling this bacteria, for example, E. coli caused the infections or Klebsiella pneumonia caused the infections, I need to know whether the Klebsiella pneumonia is an NDM1 or whether it's an OXA48. We need to remember thing one. That's most important thing there. So we need to know who is the host, what predisposes this host to get the infections. Get as much as information from the host. The treatment depends upon the host. So what is the host character? Second thing, where is the infection? Don't write sepsis alone. Sepsis need to be redefined. Urosepsis, pneumonia, UTI, bloodstream infections, meningitis. Then what organs is affected there? Whether the person has got renal failure, whether the person has got lung injury, whether the person has got hypotension recurring vasopressors or not. So what is an encephalopathy? We need to define the sepsis in terms of organ dysfunctions. What is the host character? What organ is affected? How our body responded to the infections? And final thing is, what are all the organs are affected with the sepsis? So we need to know what we are going to do now. Previous approach, what I used to do before 2009, what I used to do, where is the patient coming from? Whether the patient is coming from the other hospitals or the person is coming from the home. Why this definition is needed? Coming from home, the chances of getting resistant bug is bit less. Coming from other hospitals or recent hospitalizations, the resistant bugs can grow up. Resistant bugs can grow up. So this is a major concern. I asked, so what I do when a person is coming from the other hospital, I need to start broader. When the person is coming from home, I can start little bit narrow. This is what I used to do in 2009 and 2008. But in 2010 or 2011, when NDM1 came into market and it starts spreading into the community, this is very difficult because ESBL already spread to the community. Now carbapenem resistance also spread to the community. So this is a bit difficult for us to manage it now. So what I did from 2015 onwards, I'll start asking risk factors for resistant bacteria. For example, the person received broad spectrum antibiotic in the last 90 days. Broad spectrum means cephalosporin sulbactam, piperacillin tazobactam, carbapenems or cholesterol tetracycline like type of drugs. Second thing, recent hospitalizations. Any patient in the hospital, the chances of carrying resistant bug is very high. The person is getting hemodialysis, not necessarily hospitalizations. The person periodically go to the hospitals, done 4-hour sessions of dialysis, the chances of picking up high resistant organisms, particularly if the person is carrying central lines, not through AV fistulas or graft. If the person is operating through the central line, the chances of picking resistant bugs is very high. Then mechanical ventilations, some of the wound care. Some family member got admitted, got resistant bacteria, came back home, the chances of resistant factor. So this is what we used to do, whether the person has got any risk factors. Based upon the risk factors, I need to adjust my therapy there. So this is what we need to do. But in 2017, 2018 onwards, what we started doing, this is called increment score. How sick is the host? Whether the person is shocky, whether the person is present in severe sepsis. Second thing is called pit bacteremia score. What is the score? More than 6, the person is hemodynamically unstable. Then Charlson's comorbid index. What are all the comorbidity? Whether the person has got underlying malignancy, neutropenia, immunocompromise, COPD, CLD, we need to know what comorbid the person has got it. Because when the person carries a lot of comorbid conditions, the chances of getting severe infections is very high. Then we need to know where is the source of the bloodstream infections. If the person's bloodstream infections originated from urinary tract infections or biliary tract, this is easy to treat. Why? Most of the bacteria, antibiotic goes through the kidney, goes through the liver. It goes through the kidney, yes, we can use, let's say, antibiotic. Lot of antibiotics will go through the kidney. If the person antibiotic goes through the liver, is easy. So it's easy to treat infections originating from the urinary tract, infections originating from the biliary tree compared to any other source. For example, the person has got primary line related bacteremia, it is very difficult to treat. Then inappropriate therapy. The person went to other hospitals, they started ceftriaxone, the person becomes septic, shocky, came to you, the chances of getting resistant bugs is very high. So we need to know these things before starting the antibiotic. This is what we start using from 2017. When the increment score published in 2016, we start using increment score. Put a score, for example, severe sepsis needs straight away 5 points. The person's pit bacteremia score is more than 6, the point is 4. 5 plus 4, 9. Any score that crosses more than 8, the risk of infection is very high. We need to attack very hard. That's most important thing. Then what is happening now? Future. The future is this. When a person comes to you, because sometimes what we are seeing, we put increment score, we ask risk factors. Without any risk factors, the person is never hospitalized, never on hemodialysis, the person is never on hemodialysis, never on hospitalizations, but simply the person come back. And if you start doing the swab, previously surgeon used to do the nasal swab before operating it there. The surgeon used to do the nasal swab. Nowadays we are start doing the rectal swab. Where we learned it? Europe do it. When Asians or Indians traveling to the Europe, your rectal swab will be screened before hospital admission there. So we need to see the approach. Carbapenem resistant bacteria will be carried or not. So the future approach is do the rectal swab, do the axillary swab, find out whether the person is carrying some resistant bug or not. If the person is carrying a resistant bug, our treatment approach is be different. The person going for septic shocky, I need to treat differently compared to the person is not carrying any resistant bugs. What should be the way forward? Whether the person is carrying some resistant bug or not, put the increment score. The person is carrying some resistant bug, the index is bit high, that's called GNLR score, and the person is sick, shocky, septic, and person going for some sepsis or septic shock, we need to treat broad. The person is not carrying any resistant bug, the person is not shocky, not septic, the person is not shocky, not septic, the person is not shock, not septic, we need to give a little bit lesser antibiotic. That's most important thing there. Second part is bugs. I told about the host. Host is most important. Previous classification is easy. Community acquired sepsis versus hospital acquired sepsis. But now we are going with screening the host. Well, the person coming to your hospital, start doing the swab, find out whether he carry resistant bug or not, do a score called increment score, find out the person is carrying some resistant bugs or not. But now we need to know what bug the person is carrying. How to find out what persons the bugs is carrying? The standard of care is take 2 sets of cultures. Take 2 sets of cultures. That means 40 ml of blood. If your chances of sepsis is very high, we can use 3 sets of cultures also. In spite of 3 sets of cultures, the yield is not great. So this is a past approach, taking cultures, appropriate cultures, not everywhere. When a person is septic, shocky, what most of the ICU do? They take pan cultures, send the ET cultures, send the urine cultures, send the wound swab, send the drain fluid, send the blood, everything there. Before sending the cultures, we need to know how to interpret the cultures, why we need to send the cultures. But standard of care, septic, shocky, hypotensive patients, 2 sets of culture, that's mantra there. Previously, the culture should grow. After culture grew, they inoculate and see whether the drug is inhibiting or not. So even the culture is positive today, I can get the answer 48 hours later. I get the answers 48 hours later. So we need to wait for 48 hours without knowing whether my choice of antibiotic is correct or not. But now what is available called MALDI-TOF. MALDI-TOF will say, suppose the blood cultures you are putting in automatic system. Next day the blood culture flagging off. What we do to do, whether what organism it is present. I told earlier, Indian scenario, Acinetobacter, the resistance to carbapenem is very high. Klebsiella pneumoniae, the chances of resistance is emerging. The chances of E. coli or Pseudomonas, the resistance is going down. So the MALDI-TOF will say what bug after the culture is positive. Don't wait for one more day, do the sensitivity and find the results. So what we need to do, nowadays we got one more mechanisms. This is called film array. One of the companies is manufacturing and marketing it there right now. Previously this is validated for doing a rectal swab. When a person come to the hospitals, we need to know whether the person is carrying resistant bug or not. By doing a rectal swab, send it for the lab. Within 1 hour, we need to know whether the person is carrying NDM1 resistant bug, OXA48 carrying bug or not. We can able to say. But now where I am using, when I send the blood culture bottle, the microbiology lab calls me and saying that the blood culture is growing some bacteria. They did the gram stain shows gram negative bacteria. What I do immediately, I call the microbiology lab, ask him to do this test called Carba-R. I ask to detect the carbapenem resistant, whether the bacteria is carrying carbapenem resistant gene or not. If it is resistant, what is the resistant mechanism? Whether it's an NDM1, OXA48, IMP, WIM, we need to know what organism is going on there. That's most important for me. Most important for me to know the diagnosis there. So we need to know what organism the person is carrying. So the approach is entirely shifting. Previously I need to do the cultures, wait for 48 hours, get the sensitivity, another 24 hours, start the antibiotic appropriateness. But with the advent of MALDI-TOF, I can predict, I can predict whether the person is carrying resistant bug or not. So what should be the way forward? This is present only there. Now we are start doing that Carba-R test routinely in our patients, particularly ICU patients. Growth happened. I call the microbiology lab, ask him to do the Carba-R. But what should be the way forward? Instead of growth happening, I waiting for 24 to 48 hours. Growth should happen, then only I can do the Carba-R. But what should be the way forward? Directly from the blood culture bottle, we need to be able to do it. That is called the Septifast PCR. But the validation is happening in India. A lot of companies manufacturing and marketing it there in the name of different things. I don't want to reveal the name, but the problem is all are in-house. It is not validated. But in European situations, it is very much validated. The validated is going to hit Indian market soon, either December 2019 or early part of 2020. You are going to get the answer. When the person come to emergency or the person come to the ICU, the person is septic, shocky, you are taking the cultures, they do the direct PCR. Within 1 to 2 hours, you know the organisms, you know the resistance before you start preparing the line for IV antibiotics. This is the way forward in identifications of the bacteria there. The final part of my talk is what antibiotics. What antibiotic I need to use for sepsis. The order of syndromes. So how the antibiotic I am selecting there. First thing I need to make a diagnosis. Whether the person is septic or not. If the person is septic, the previous classification sepsis is fine. But according to the new classifications, Sepsis means what sort of the host, whether the host is really sick or not, where is the organisms coming from, pneumonia, intraabdominal sepsis, urinary tract infections, bloodstream infections, meningitis, skin and soft tissue. We need to know that's most important thing. What bacteria is we are carrying it, whether it's gram negative, gram positive, what sort of resistance, whether it's a carbapenem producing organisms, ESBL or colistin resistant bacteria, and whether you are starting antibiotic empirically. When the person come to your hospitals without knowing anything, we are starting that's called empirical, or after knowing the organisms, we are starting that's called, after knowing the organisms, it's called definite therapy. And what are all the common bugs or common drugs used in ICU? The common drugs used in Indian ICU were BLBLIs like piptazo, cephalosporin sulbactam, cefepime tazobactam, but carbapenem is also still used, colistin, polymyxin B, tigecycline, doxycycline, minocycline, lot of things we are using it there. These are all called carbapenem sparing regimens there. So how I am choosing antibiotic? Antibiotic depends upon the spectrum. Suppose the person come to me shock, septic, urinary source I am thinking there. Urinary source is usually caused by gram-negative bacteria. So my antibiotic should cover gram-negative bacteria. When the person is a shocky, not responding to adequate fluid challenge, I need to start with an colistin there, because the person's developing resistant bug is very high. If it is a urinary tract infections, the person is not moving forward. I need to think about it whether enterococci, 1 gram positive organisms causing urinary tract infection is enterococci. Whether it's because of the gram negative or whether because of the gram positive. Why? I need to know the spectrum of antibiotics. Unless we know the spectrum of the antibiotic, it's very difficult for you to start the antibiotic in ICU. For example, if you start using carbapenem, we need to know carbapenem will cover routine gram negatives, ESBL gram negatives, but not carbapenem is producing gram negatives. Similarly, if you are using tigecycline, most of the things is taken care. ESBL producing Enterobacteriaceae, carbapenem producing Enterobacteriaceae, but tigecycline won't cover Pseudomonas, Proteus, Providentia. Colistin cover most of the bacteria, but what colistin won't cover? Proteus, Serratia, Burkholderia. These things are not covered by colistin. So we need to know the spectrum before you write the antibiotics. But now the mantra in sepsis and ICU is individualized medicines. We need to know the pharmacokinetics and pharmacodynamics. For example, if you are using piperacillin tazobactam for a septic patients, we need to use 3-hour doses of antibiotics. Instead of giving 30 minutes, if you use 3 hours dose of antibiotic, it is very easy for you to know what is going on there. That's most important. Similarly, if you are using vancomycin, we need to use a high loading dose to reach the area and the curve. That's most important thing there. So a little bit of pharmacokinetics and pharmacodynamics, that is most value for you there. Then regarding the timing, the Kumar's paper created a lot of confusions. If you delay the antibiotic choice, if you delay the antibiotic timing, the person will not go back home. But now the concept is slowly changing. The concept is slowly emerging and changing. The emerging shows, first thing we need to decide whether the person is septic or not. Take your time, decide whether the person is really infected or not. Second question, whether the person is septic, shocky or not. The person is shocky, the person has got suspected infections, we need to start antibiotic, do not wait. On the other hand, it's a 50-50 situations, the person is hemodynamically stable, the diagnosis of sepsis is not correct, and the person is hemodynamically stable, is fit enough to go to the HTU, I can wait for starting antibiotics. So this is a mantra you need to know there. So which guidelines to follow? Lot of guidelines, Western guidelines, lot of things there. Indian guidelines, each one talks about it there. For example, Indian Society of Critical Care Medicines recently published the guidelines. ICMR has got the guidelines, but all the guidelines for me, it's a cut copy paste. Cut copy paste without knowing the Indian epidemiology. That's why I dwelled on time Indian epidemiology. What bugs we are dealing with it, what resistance we are dealing with it. I told Indian bugs are different, Indian resistance mechanisms also are different. So cut copy paste will not work in Indian scenario. That's most important thing. In Indian scenario, we need to create our local guidelines. We need to think about our guidelines. What bug in my hospitals? What drug will work in my hospitals? Based upon the thing we need to start. So, how to start the definite treatment? There are two entities I mentioned. One is called definite. Second thing is called empirical. In definite treatment, that means the person admitted, you made a diagnosis of sepsis, for example, urosepsis. You send the cultures. The culture is growing in bacteria. Now we need to know what bug is growing. The bug is going to be carbapenemase producer or not, whether it's an ESBL producer or not. If it is an ESBL producer, lot of options. If it is a carbapenem-based producer, the options are very limited. Then people want to know, I know this is a bacteria, it carries E. coli, it carries Acinetobacter in the blood. Whether I want to start with one therapy, I started 2 antibiotics. But now whether to switch back to one antibiotic or I need to continue 2 antibiotics, people keep on asking me there. Yes, once you know the bacteria is to be Acinetobacter, once the bacteria is turned to be a Pseudomonas, we have started double cover initially. Even for Pseudomonas I am talking, even for Pseudomonas, only one antibiotic is sufficient provided the antibiotic is sensitive. For example, colistin means colistin sensitive. Phosphomycin, people don't want to use phosphomycin as a monotherapy, but if the source is urinary source, you can use phosphomycin also as a monotherapy. So depending upon the source, depending upon the bacteria, we can go with the monotherapy for most of the situations except Enterobacteriaceae. For example, the person is carrying Enterobacteriaceae. What I need to know, Enterobacteriaceae, I usually consider combination therapy in situations like I'll show in a minute later. But these patients are ESBL producing organisms going to the HTU, relatively stable. For example, the person requiring some hemodynamic supports in the form of fluids, no vasopressors, minimal oxygen or NIV oxygen. I can start with this antibiotic. For example, the person presents with urosepsis, I can try aminoglycosides, I can try fluoroquinolones, I can try cotrimoxazole, I can try BLBLA versus carbapenem. If it is an intra-abdominal sepsis, I can use BLBLA provided it's sensitive. I can use doxycycline, I can use chloramphenicol. Particularly for SSI, skin and soft tissue infections, IV doxycycline, high dose doxycycline is also available. It's a good molecule there. Community acquired pneumonia, yes, we can use ceftriaxone, we can use amoxiclav, we can use IV doxycycline. That will take care some of the bugs like H. influenzae there. Meningitis, ceftriaxone is still gold standard. If you think the person has got community acquired, not community acquired, hospital acquired bacteria, we need to start him on ceftriaxone, chloramphenicol or meningitis. Considerations, newer drug or older drug like phosphomycin, colistin can be avoided for an ESBL producing organisms. The person is hemodynamically stable, I don't want to use it there. For a definite treatment for a carbapenem-based producing organisms or a patient is a septic, the person is septic, carbapenem-based producing organisms going to ICU, what I need to do, the culture back come back showing carbapenem resistant Acinetobacter, colistin sensitive, I start using colistin or polymyxin B. Carbapenem resistant Enterobacteriaceae, carbapenem resistant Klebsiella pneumoniae, the bloodstream infection is present there. The person is shocky, the person is not improving, central line is very difficult to remove. That point of time I need to use combination therapy. So combination therapy, Enterobacteriaceae infections, the person is shocky, the source control is not appropriate, the person is a neutropenic host, isolates with very high MIC to colistin, we need to use a combination therapy. And the source is a known source, easily controllable source, even though the person is shocky, but we know the organism is Acinetobacter, the organism is a Pseudomonas, then we can give monotherapy. For Enterobacteriaceae, the organism is sensitive, the person is slightly better, we can continue the monotherapy. If we started combination therapy, the started patient improving, source control happening, switch back to one drug, that's most important thing. So the other difficult question is empirical therapy. The patient is coming to your hospitals, I do not know what bug is carrying on. The person come to your hospitals, I need to ask the questions whether the person is coming from community or hospitals. If the person is coming from community or hospital, any risk factors for resistant bacteria, any risk factors for resistant bacteria is there or not, that's most important thing. Particularly I need to check the hemodynamic stability of the patients. The person is hemodynamically unstable, the person is carrying some resistant bugs is possible there, then I need to start combination therapy, preferably colistin plus or minus phosphomycin or colistin polymyxin B, either colistin or polymyxin B plus or minus meropenem. Suppose the person is really shocky and the person exposed to a lot of antibiotics in the past, we need to consider one of the newer avenue called ceftazidime avibactam, going to hit Indian market soon along with histrionum. That will cover all the things there. Suppose the person is hemodynamically stable, coming from the community, no risk factors for antibiotic resistance, you can get away with colistin alone, or you can get away with carbapenems also there. Some of the time the BLBLAs may work. So empirical therapy, where is the patients, what is the risk factors, whether he carry resistant bug or not, whether the person has got risk of antibiotic exposures or not, and how shocky is the patient. Shocky patients, don't take chance, use combination therapy. The person is stable, you can try with monotherapy. This is what we need to do in empirical therapy situations. In short, and I want to go my hospital for accreditations for NABH, JCI. Yes, how to get the accreditations also will sort out your problems. I want to consult ID consults because some of the patients are tough. They wanted me lot of questions there. I need to answer as far as infection is concerned. Yes, via telemedicines we can able to provide you consult services. If you want to do research collaborations, lot of patients I am seeing. Unfortunately, I am not producing any paper from my hospitals. I need to associate with you. I will provide the data. We can collaborate and we can write a paper. Yes, we are accepting the papers also there. And daily ID lining. The best of ID is one of the WhatsApp group circulating the messages to you. 5 or 7 points, important points. They convey the messages to you. You can learn it. The best of ID. If you want to learn, just write back to me. I'll provide the slides to you. I can include in the best of ID WhatsApp group so that you can learn it. Or you can create a WhatsApp group. The messages will come to you soon. I thank sincerely the Fusion Pharmaceutical for giving this wonderful opportunity. I'm happy to take any questions from your side. I'm happy to answer anything there. Thank you very much. Say, procalcitonin help to stop antibiotic, particularly for pneumonia syndrome for bloodstream infections. In general, the other question is now, in general, in ICU patients, we prescribe antibiotics. In some patients, we see clinical improvement, but no change in the lab parameters. While others, we see lab improvement, but no change in the clinical improvement. So how often can we change the antibiotics or step up antibiotics in these patients? Really, really a good one there. So what we usually say is, in spite of what we usually do is, instead of what we usually do is, 1 second, I'll come. We usually do in the presence of aseptic patients, the most important parameter is clinical parameter, not the lab parameter. I used to treat my fellows, I used to treat my trainees, I used to teach my trainees, treat the patient, not the paper. Treat the patient, not the paper. The paper and patient is correlating well and good. If the paper and patient is not correlating, treat the patient. Patient is clinically better, the patient is improving forward, even though the lab parameters are not moving forward, sufficient durations of antibiotic is given, you can stop the antibiotic. Suppose the person is not moving forward, even though the bacteria is turned to be a sensitive bacteria, what I need to do? Reassess my diagnosis, whether my diagnosis is correct or not, whether my antibiotic choice is correct or not, whether my antibiotic goes into the tissues or not, pharmacokinetic. For example, the person you made a diagnosis of urosepsis turned to be candida, but it is resistant to fluconazole. You started echinocandin, micafungin, but the person is micafungin is sensitive in the lab, but the person is not moving forward. Why? Micafungin will not reach the urine. Micafungin will not reach the urine. So what we need to do? We need to reassess our diagnosis. This is candida urosepsis. The sepsis is originating, fluconazole resistant. So my choice of antibiotic or antifungal here, change over to amphotericin B. That's what we need to do the thing there. So the person is not moving forward, give importance to patient, not the paper. Suppose the patient is also moving forward, you try to see the paper in the form of procalcitonin. But procalcitonin alone has got no value. Think about the clinical improvement. Along with the procalcitonin, it may help out. So between the patients and paper, I give importance to the patient. Sir, can we give tigecycline in urosepsis? Instead of tigecycline, that's what I dwell. Tigecycline sensitive, doxycycline sensitive. What I do, I use doxycycline. Why? Doxycycline, the level in the urine is much higher compared to tigecycline. No other go, Tg is alone sensitive. Colistin I cannot use for some other reason there. Then I can use double the dose of tigecycline and wait for the response. If the response is not appropriate, I need to switch back either to the colistin. Don't use polymyxin B for urinary sepsis. Among the polymyxins, the polymyxin of choice for urinary tract infection is colistin. Polymyxin B is not the choice for urinary tract infections. So among the options, if other option is there, for example phosphomycin is there, I can go phosphomycin. Aminoglycoside is there, aminoglycosides. If both are not there, only Tg and colistin, but for some reason colistin I cannot use, I can go with the doxycycline. If doxycycline is not sensitive, then I can use high dose tigecycline. That's what I used to do there. Any other questions, I'm happy to take. In case any questions, you can write back to me there. If you are really interested about learning best of ID, daily we are giving a teaching 4 or 5 points, important ID points, how to learn as well as IDPL. You form a WhatsApp group, include my name and send it to me there. I'll send you the slides to you there. Initial couple of months it is free of subscription there. You can learn it if you are comfortable. When subscription started, you can switch back to the subscription mode also there. Any questions, we are happy to take, as well as any clinical consults also we can able to do with the telemedicine nowadays there. One more question is coming up now. I clearly answered it there. Caspofungin, micafungin, anidulafungin. None of the candins will go into the urinary system. If it is an urinary tract infections, fungal as urosepsis, azoles are sensitive, fluconazole is a drug of choice. Suppose voriconazole sensitive, fluconazole resistant, do not use voriconazole. Voriconazole will not go into the kidney, voriconazole will not go into the urine. So the drug of choice is either azole or you can use amphotericin B. Nothing is working, ask the lab to check for flucytosine. Flucytosine will go. Nowadays a lot of companies are manufacturing flucytosine. Yes, we can use flucytosine as a last resort, but no role for candins, no role for voriconazole. One more thing is coming up there. Just is the role of contact isolation precautions for MDRO. It's my pet talk. I used it all because I do a lot of infection control as an NABH assessor also. I used to do a lot of things there. What is about the contact isolations? People always keep all the things. For example, they keep gloves, they keep gowns, they keep separate stethoscope, everything there. But none of the healthcare personnel, particularly the doctor community, will wear the thing and go into the patient room there. They just go inside. If at all, some of the doctors can use hand rub, some of the doctors can use the gloves, but none of them put a gown. So what is the contact isolation precautions I do in my hospitals? I ask them to do good hand hygiene. If you do a good hand hygiene before touching the patients and after touching the patients, that is more than sufficient. With a good hand hygiene, if you are not able to reduce the rate, you can go with the fancy stuff like gloves, gowns, keep the patients in a separate room, another thing you can do it now. That's other you can do. So contact isolation, yes, try simple thing like doing a hand hygiene. If hand hygiene is not working, consider doing it other strict measures like other thing there. So one more thing is coming up now. Does Staph aureus led to sepsis, and if yes, MSSA is more prevalent than MRSA? I have recently received ascorbic acid helps reducing mortality rate in septic patients. High dose ascorbic acid. I need to check the high dose ascorbic acid. I also saw the paper, but I not dwelled in detail. But yes, we need to look into the thing there. I need to speak to my intensive care consultant. That's easy to answer. Regarding the MSSA or MRSA, yes, MSSA is still more common compared to the MRSA. Unfortunately, for MSSA, a lot of antibiotic came into the market. Some of the molecules like your flucloxacillin there. People marketing like Fusion has got Staphonex. We can use both IV as well as step down therapy oral. Now for infective endocarditis, we are using from day 21 days later, 3 weeks onwards. 3 weeks later, we can switch back to oral therapy also. That's possible there. So MSSA is still common compared to the MRSA. The drug of choices for MSSA either flucloxacillin, cloxacillin, or your cefazolin there. So cefazolin nowadays very difficult to get the cefazolin. Flucloxacillin is freely available. Either you can use flucloxacillin or cloxacillin. If you are able to get the cefazolin, cefazolin is also fine there. So yes, MSSA is more common. As far as ascorbic acid is concerned, I need to speak to my intensive care. I saw the paper, but I need to dwell in little detail. I got another thing there. I have questions. What is the role of antifungal in diabetic patients with sepsis immunocompromised? I think I answered this one. Diabetic are not vulnerable except two funguses. Mucormycosis in the form of cellulitis, particularly orbital cellulitis, and the chances of UTI is bit high. If you start antifungal agent, which antifungal do you advise? I clearly told there. One more questions I am expecting there. So meantime, if you want to learn more ID, couple of conferences is coming up there. One is in June for people to do infection control. People want to accredit your hospital with NABH. That's a simple thing we can do. It's easy for you to get NABH accreditations. And second thing, if you want to have ID consults, we can able to provide you the telemedicine backup there. We can able to do it. And third thing is hands-on ID training. Yes, we can able to provide you there. Yes, I got other question there. Can we use ferropinum in place of meropenem from IV to oral switching? Ferropinum is a molecule available in Indian scenario, but no data. How to check ferropinum, whether it work for E. coli, whether it work for Klebsiella? You ask the manufacturer of ferropinum to provide the data, Indian data, how to check what is the cutoff and what is the data, in vitro data. That's most important thing. The person should provide the data, cutoff, everything there, then only we can use to do the ferropinum. But for me, most of the time ferropinum, the drug, there is no cutoff, so we are not using it there. We are not using ferropinum as a step down therapy. This is not a carbapenem. Don't consider ferropinum as a carbapenem there. In acute kidney injury patients, colistin single dose versus split dose, which is effective. Usually colistin is more of concentrations or area under curve by concentration there. It's not time dependent antibiotic, but the beauty is the post antibiotic effect is not that great there. So colistin in the presence of renal toxicity, use once daily therapy, that's more important, or sometimes we can use once in 48 hours also, depending upon the creatinine clearance. Usually we use for a dialysis patients 2 million before dialysis and 1 million after the dialysis we used to give, or you can give all 3 million after the dialysis session is over, we can give it there. So colistin for renal patients, once daily compared to twice daily therapy. Doxycycline in tropical sepsis. Usually people say 200 loading dose followed by 100 milligram, but for gram-negative sepsis, multi-drug resistant organisms, high dose is a good dose for me there. Tropical stuff like Streptotyphus, leptospirosis, yes, we can load with 200 milligram to reach a target and convert it to 100 milligram BD. But for MDRO, gram-negative sepsis, 200 stat followed by 200 milligram BD is required. Any other questions from your side? Market, can it be placed as an amoxiclav? Yes, both Ampicillobacter and amoxiclav has got a good options, particularly in case of Acinetobacter sepsis. The sepsis is under control. Day 4 to day 5, particularly the source is from a community acquired pneumonia or hospital acquired pneumonia. Acinetobacter, after treating with an IV antibiotic, if Ampicillin-Sulbactam oral option is available, you can switch back to Ampicillin-Sulbactam. It has got advantage over compared to amoxiclav, particularly for Acinetobacter, since Sulbactam has got action there. If it is available, yes, Ampicillobactam can be tried, because Ampicillobactam is a recognized combinations compared to a lot of irrational combinations like ceftriaxone. So many things are combined there, so that's a bit difficult to use it there. Any other thing? It's a nice interactions. I'm happy to answer your questions through my mail also there, and as I said earlier, a lot of things is coming up. Keep watching Best of IDs there. Thank you. So what is your take on treatment of MDR Pseudomonas VAP with inhalational colistin along with IV, and what dose and device? Device I'm not sure. Okay, fine. So what is the treatment for MDR Pseudomonas? I just now dwell treatment for MDR Pseudomonas. Once you know the bug, I told clearly the options of antibiotic. Before start writing the antibiotics, we need to know whether it is a definite therapy or it's an empirical therapy. Your question fits into definite therapy. You know the bug, that is MDR Pseudomonas, and your diagnosis is also VAP. The organism is coming from the pneumonia there. So we need to use an agent to cover the Pseudomonas. That agent should go better into the lung or alveolar fluid. That's the most important thing, we need to do it. So what is the best thing for Pseudomonas? You said MDR Pseudomonas means carbapenem resistant bacteria, I hope, because now the terms of MDR is slowly given up. We need to know the resistant mechanisms. Carbapenem resistant Pseudomonas, I assume it's a carbapenem resistant Pseudomonas. So what should be the treatment options for carbapenem resistant Pseudomonas? For me, couple of options is there. One, colistin. Either colistin means polymyxin B or polymyxin E. Second option, phosphomycin may work for Pseudomonas. The tigecycline, minocycline, doxycycline will not work. So what is going to work for you? Either carbapenem will not work because you are saying MDR. So colistin or polymyxin B. Phosphomycin will work. What will work? Aminoglycosides may work for this bug. So what to use? Ideally, if you know the person is not shocky, the person is not neutropenic, I'll go with the one therapy called colistin IV systemic. I can go with the colistin good dose. Whether they do inhalation therapy, yes. But the problem with inhalation therapy, need jet nebulizers. Whatever nebulizers in ICU is not going to push your colistin inside the lung. Whatever nebulizer you are using, push the colistin up to the trachea level. But the problem you are saying is VAP. So there is no benefit of giving inhaled form of it. Couple of papers emerging now, combining of colistin IV plus inhalation colistin may help the patients. But the studies conducted with jet nebulizers, Indian scenario, IV colistin for a stable non-neutropenic host. If the patient is a neutropenic host, septic, shocky, not moving with colistin, as a last resort you can try inhalation colistin or combination therapy as a last resort. Because I told clearly Pseudomonas Acinetobacter, monotherapy is mostly sufficient. The person will start doing well. Unless the person is not doing well, it's a bit difficult for you there. The other questions, the second question also came up now. What about the biofilm formations? Couple of antibiotics has got biofilm applications. For example, if you think Pseudomonas, particularly for an osteoarticular infections, prosthetic joint infections, I do a lot of prosthetic joint infections dealing there. The prosthetic joint infections, the biofilm will form over the joint. It's a bit difficult for to treat. That point of time, Pseudomonas plus rifampin, that's a wonderful drug. Rifampin is a wonderful drug for biofilm. Other drugs like carbapenems has got little bit biofilm effect, but as far as is concerned, colistin is also okay for me, little bit of it. But the best biofilm effect is rifampin. So if you want to use, you can use for a prosthetic joint infections, prosthetic valve infections, you can combine rifampin. Otherwise, for routine biofilm, biofilm in central line, you need to remove the central line in ICU if possible. If the central line is a permacath, it's a bit difficult to remove, you can use a lock solutions there. That's an answer rather than going for a good biofilm effect, because most of the antibiotic like BLBLIs, the biofilm effect is not that great. Carbapenem is good, biofilm effect will be there. Colistin has got moderate biofilm effect, but the best biofilm effect seen with the rifampin. Rifampin don't consider only for TB, it has got a good action for Staph aureus, good biofilm effect is also there. Any other questions there?
The next number is
Always monotherapy is much better. Whether it's Acinetobacter, Pseudomonas, after knowing the sensitivity, use monotherapy. On the other hand, Enterobacteriaceae, the person is a shocky, neutropenic, source control not appropriate, use combination therapy. Most of the time, monotherapy is sufficient, except on few occasions which I told little time earlier. What is most important thing? I talked about the antibiotics, but most important thing in ICU, now the mantra is not de-escalations, the mantra is discontinuations. Discontinuation of antibiotic. Almost most of the antibiotics we need to treat 3 to 5 days. For example, 5 to 7 is a reasonable number. The new mantra is 5 to 7. Even for Enterobacteriaceae bacteremia, we need to treat like a 7 days. We need to treat 7 days, not 10 days, not 14 days. Provided source control happen, provided the person is not shocky, the person is not septic, we can cut down the durations. Community acquired pneumonia 3 days. Intra-abdominal sepsis 4 days. In the presence of bloodstream infection 7 days is fine there. If not, you are not sure what is going on, if a person is not sure, I can go for a de-escalations. De-escalation means, for example, you start a combination therapy without knowing, or the person is really septic, shocky, source control is not appropriate. But later, 48 hours, you can able to control the source. The line is out, the person start moving forward, hemodynamically stable. You can cut down one therapy. For example, you start colistin plus meropenem. I can start the meropenem once the person gets stabilized. This is called de-escalations. But de-escalation is a last resort. Discontinuations, for me, I can continue the colistin meropenem for 5 to 7 days. I can stop the meropenem and colistin. Instead of continuing colistin for 10 to 14 days, I can stop both the things on day 7. That give good to the patients. That's most important thing. So in ICU, we need to know when to stop. That's most important thing there. So in short, what be the summary of antibiotics? Antibiotics are not antipyretics. That's the message. That's the take home message you can consider. Don't consider antibiotics or antipyretic. First thing is whether the person is septic or not, whether the person require antibiotic or not, take your decision. That's most important thing. And don't consider antibiotic is a drug of fear. If I fail to give my treatment, the patient will not go back home. That's the mantra is gone. You need to take your time. Lot of faster modalities of diagnosis is available in Indian scenario. Lot of faster modalities available in Indian scenario. We need to give the antibiotics to treat the sepsis, not to alleviate your fear. By chance some infection is there, that thought process should go away from your mind there. So what should be the summary? Try to identify the antibiotic, try to identify the sepsis, try to identify the infections, try to identify the pathogen, try to identify the resistance mechanisms also there. Try to decide whether to start antibiotic or not. Take your time, decide whether to start or not. If you decided to start, don't wait. If the person is sick, the person is shocky, the person is neutropenic, the person is source control is not appropriate, try to start broad. If the source control is possible, if you know the source of the bacteremia, start little simpler. Stop antibiotic, that's most important, rather than de-escalations. Stop the antibiotics on day 5 to day 7 instead of continuing the antibiotic for 10 to 14 days. Remember, if any help, one modality is called best of IDs. This is a small startup that helps to choose your antibiotics. If you got any problem in your ICU, if you got any problem in accreditations of your hospitals, if you got any sick patients, the best of ID is a small startup that is going to help you out there. Now the results is out. I am talking about antibiotic selection results I just now put. I'm not talking about other things there. So you need to start one therapy. That's what I'm talking about it. Monotherapy, not a combination therapy. I'm not politicizing anything there. I'm just talking about the antibiotic selections in the ICU. If you know the bug, if the patient is stable, one drug is enough. If you do not know the bug, the person is shocky, the person is not improving, you need to start 2 or 3 antibiotics. This is a summary for you there. My last slides, what is coming up? If you got a lot of things is there. One of the infection control or infection prevention conference we call nurses and microbiologists can attend in June 2019. One of the major conference called ID in ICU, we are opening in July 2019. We'll just release the dates to you there. Those who are interested, you can attend the thing. Then infection control and prevention certifications. Some of the nurses find difficult there. They are finding difficult to do the thing. Infection control and preventions. We can do the certification courses from us. Best of ID is one of the startup. Its planning is the first annual event in November 2009. Hands-on ID. I like to know this one session is not going to solve your problems. I learn ID by hands-on because in my place there is no ID. But I need to learn ID by doing a hands-on training. Yes, you are welcome. You get the certification. Get the infections. Tough one to answer. I think I answered last time in Best of Brussels conference there. Where to use doxycycline. Because most of the labs as a first line they check for BLBLIs. As a first line they check for carbapenems. Some of the labs they check for cholesterol and digicycline. Doxycycline for an initial check, most of the labs they are not doing it there. They do as a second line. When the carbapenems are resistant, they start checking for the doxycycline. Yes, doxycycline is a good drug. What are all the situations? In the presence of skin and soft tissue infection, good drug. In the presence of community acquired pneumonia, it is a good drug. Intra-abdominal sepsis is okay for me. But where you should not use, doxycycline is not a good drug for urinary tract infections. Doxycycline penetration to the brain is not great. So if it is a skin and soft tissue, if it is a pneumonia syndrome, if it is an intra-abdominal sepsis, yes, I can use, provided the bug is sensitive to doxycycline and no other good options. The person is hemodynamically stable. But the problem with doxycycline, we need to use high dose doxycycline similar to your tigecycline. 200 milligram loading dose followed by 200 milligram BD dose, you can use doxycycline. If a good dose of doxycycline, the presence of skin and soft tissue, the presence of community acquired pneumonia as well as hospital acquired pneumonia, the presence of intra-abdominal sepsis I can consider, not for urinary tract infections, not for meningitis. If it is a meningitis, I would prefer to go minocycline rather than doxy. Tigecycline is the least one. Similarly, the person is carrying urinary tract infections. 3 drugs are sensitive: tigecycline sensitive, minocycline sensitive, doxycycline sensitive. I prefer doxycycline. Particularly, the patient has got some renal nephrotoxicity with the cholesterol. Cholesterol sensitive. The person has got tigecycline sensitive, minocycline sensitive, doxycycline sensitive. I prefer doxycycline over cholesterol. I prefer doxycycline over TG, doxycycline over minocycline, provided the patient is stable. That's what I can able to do there. One more question has come there. What is the role of antifungal in diabetic patient who is in sepsis or immunocompromised patients? If you start antifungal, which antifungal do you advise and how early is prescribed? The mantra is simpler. Always I told the same principle what I just now told for antibiotics. What I told for antibiotics, you need to apply the role for antifungal. First thing, we need to make a diagnosis. Whether the person is infected with fungus or not. Whether the fungus is invasive fungus infections or not. Or whether it's an invasive candidiasis or candidemia or not. We need to know these things. If you know these things, then it's easy for you to answer the thing there. Diabetic host is not vulnerable to fungal infections. Poorly controlled diabetic, vulnerable for 2 fungal infections. One, the person's chances of developing invasive fungal sinusitis and orbital cellulitis due to mucormycosis. Second thing, candidal UTI is possible there. So these type of situations, if it is an invasive sinusitis or orbital cellulitis, I would prefer amphotericin B. That's a drug of choice there. Suppose the person has got candidal UTI because of the poor diabetic status, I can prefer either fluconazole in a hemodynamically stable patients because fluconazole reaches the kidney as well as the urine. Your caspofungin, handolafungin, micafungin will not reach the kidney or urine there. So if it is a urinary tract infections, if you think candida, your candida is not yet a risk factor or resistant to azoles, use fluconazole. Suppose the candida is resistant to azoles, we need to use amphotericin B there. So diabetic host is easy. The sinusitis versus UTI. Otherwise, diabetic foot and other infections is not vulnerable for fungal infections. Immunocompromised. What do you mean by immunocompromised? Whether it's a solid organ transplant, whether it's a bone marrow transplant, whether it's a steroid exposure. Solid organ transplant, bone marrow transplant, after sufficient durations of the anti-chemotherapy or the transplant medications, they are vulnerable from day 30 onwards. That point of time, yes, I can consider some invasive fungal infections. We can use either echinocandin or we can use amphotericin B as a broad. If you know that fungus is turned to be aspergillus, we need to convert it into voriconazole. Other person is asking, what is the role of procalcitonin in deciding mono or combinations? The answer is very clear. This is the easiest question I can answer you there. Procalcitonin will not help you to make decision to start antibiotic. Procalcitonin will help you to stop the antibiotics, particularly for pneumonia syndrome, particularly for sepsis syndrome. If you think the person is septic, the person's source of sepsis is community acquired pneumonia or hospital acquired pneumonia, you started the antibiotics. Now the mantra is 5 days is sufficient. At the day 4, day 5, the person is clinically better. You are not sure whether you want to stop the antibiotic or not. You do the procalcitonin. Procalcitonin tend to be normal. On 2 occasions, you can stop the antibiotics. For starting antibiotic mono or combinations, whatever value procalcitonin also